Welcome to this explainer on the absolute most common lysosomal storage disorder in the world. Today, we're breaking down Gaucher disease. So if you're gearing up for your boards, sweating through your pediatrics rotation, or honestly, just love cracking a complex clinical puzzle, you are exactly where you need to be. Let's get right into it. Let's kick things off with a clinical mystery. Imagine a young child walks into your clinic. They've got a massively enlarged spleen, they're noticeably pale, bruising super easily, and they're complaining of severe, relentless bone pain. You order an x-ray, and it shows outright destruction of the long bones. You take a look at the bone marrow, and it's literally packed with these abnormal, lipid-filled cells. Now, when you see a young patient with bone pain, a huge spleen, and packed marrow, your mind is probably jumping straight to common childhood cancers, right? Like leukemia or lymphoma. But here's the twist. The true culprit here isn't a malignancy at all. It's Gaucher disease. This completely devastating presentation is actually the result of just a single missing lysosomal enzyme that sets off a massive cascade of progressive organ dysfunction. Here is our roadmap to mastering this efficiently. We're going to cover the genetic origins, the pathophysiology, the different types, how to diagnose it, how to treat it, and we'll wrap it all up with some high-yield exam pearls. All right, Section 1, the origin story, genetics, and the GBA1 mutation. So, because this is an autosomal recessive condition linked directly to mutations in the GBA1 gene, every single pregnancy for carrier parents comes with a 25% chance of having an affected child. There's also a 50% chance the child is a carrier, and a 25% chance they're completely unaffected. And you absolutely need to remember this for the exams. This disease, particularly type 1, is significantly more common among individuals of Ashkenazi Jewish ancestry. Moving right along to Section 2, pathophysiology, the modus operandi. Okay, let's look at what's actually happening at the cellular level. Normally, when old blood cells are broken down, their membrane lipids get degraded. The enzyme beta-glucocerebrosidase swoops in and smoothly converts a lipid called glucocerebroside into glucose and ceramide. The result? A perfectly healthy lysosome. But in Gaucher disease, that crucial enzyme is deficient. Without it, that glucocerebroside lipid doesn't get degraded. Instead, it just piles up inside the lysosomes of macrophages, turning normal, healthy cells into these bloated, wildly dysfunctional entities that we call Gaucher cells. Think of it like a terrible domino effect. You start with that GBA1 mutation, right? Which leads to the enzyme deficiency, which then causes a massive lipid buildup, creating those Gaucher cells we just talked about. But here's the real problem. The damage doesn't just stay confined to a single cell. Those Gaucher cells start unleashing inflammatory cytokines and physically infiltrate key organs. We're talking the spleen, the liver, the bone marrow, the lungs. That widespread infiltration is exactly what drives the systemic chronic inflammation and that severe bone destruction we see in our patients. Up next, Section 3, types and features, the victims. Let's break down who gets hit the hardest. As you can see, type 1 absolutely dominates here, making up about 90 to 95% of all cases in many populations. This is the non-neuronopathic form, which means, thankfully, it totally spares the central nervous system. And with the right treatment, type 1 patients can actually have a near-normal life expectancy. On the flip side, types 2 and 3 are way rarer, but they tragically involve severe neurological deterioration. Type 2 is acute, begins in infancy, and is sadly often fatal within just the first few years of life. Type 3, well, that has a childhood onset with a much slower neurological progression, bringing on things like horizontal gaze palsy and ataxia. Now, for our type 1 patients, the physical toll is just brutal. Clinically, you're going to see massive splenomegaly, which causes early satiety, right alongside hepatomegaly. Hematologically, we're dealing with anemia causing severe fatigue, and thrombocytopenia, which leads to easy bruising and bleeding. But honestly, one of the absolute most disabling aspects is the skeletal involvement. These patients endure awful bone pain, osteopenia, pathological fractures, and this highly characteristic abnormal bone remodeling on x-rays known as the Erlenmeyer-Flask deformity of the distal femur. Seriously, it literally looks just like the bottom of a high school chemistry flask. That is a visual you 100% want to burn into your brain for test day. All right, Section 4. Diagnosis, the evidence. How do we actually prove this is what's happening? Well, that brings us to the hallmark histological finding, the Gaucher cell. Guys, this is an absolute buzzword for your medical board exams. It's this large macrophage with an eccentrically placed nucleus, and its cytoplasm is so entirely stuffed with lipids that it takes on this incredibly distinctive wrinkled or crumpled tissue paper appearance. You're typically going to find these cells infiltrating the bone marrow, the liver, the spleen, and the lymph nodes. But here's the thing. Spotting a crumpled tissue paper cell on a biopsy isn't actually how we prefer to make the call. To nail down the diagnosis definitively, you want to follow these exact steps. Step 1, the absolute gold standard, is measuring the beta-glucocerebrosidase enzyme activity in leukocytes or cultured fibroblasts. If that activity is markedly reduced, boom, you have your diagnosis. Step 2 is genetic testing for the GBA1 mutation. That confirms it and really helps with family screening. And step 3 is imaging, specifically getting an MRI, which is by far the best way to assess the true extent of the skeletal and bone marrow disease. So remember, we always prioritize that blood test for enzyme activity way over doing an invasive bone marrow biopsy. Moving to section 5, treatment, the resolution. Good news here, we actually have ways to fight this. We generally have 2 major therapeutic avenues. The absolute cornerstone of treatment for type 1 is enzyme replacement therapy, or ERT, using drugs like imiglucerase. We literally just supply the missing enzyme to help reduce the liver and spleen size, improve their blood counts, and decrease that awful bone pain. Now, the catch is that ERT enzymes don't effectively cross the blood-brain barrier, so unfortunately they have really limited benefit for the neurological symptoms we see in types 2 and 3. Alternatively, for selected adult patients, we can use an oral substrate reduction therapy, or SRT, like alligostat. Instead of just replacing the enzyme, SRT actually works upstream to reduce the production of that glucocerebroside lipid right at its source. Pretty clever, right? And finally, section 6, exam pearls, the cheat sheet. Let's lock in those points for test day. You know that exams absolutely love to test Gaucher against other lysosomal storage disorders like Fabry and Pompe diseases, so seriously, burn this rapid comparison table right into your memory. Gaucher is autosomal recessive, you're missing beta-glucocerebrosidase, you're storing glucocerebroside in macrophages, and you've got severe bone involvement. Now contrast that with Fabry, which is X-linked, and features things like angiokeratomas, or Pompe, which goes after muscle cells and usually presents with cardiomyopathy. You really have to keep these distinctions crystal clear. Honestly, if you remember nothing else from this entire explainer, just let the word Gaucher itself trigger every piece of data you need. Ready? G is for glucocerebroside deficiency. A is for anemia. U is for unusual bone pain. C is for those crumpled tissue paper cells. H stands for hepatosplenomegaly. E reminds us that enzyme replacement therapy is the specific treatment here. And R, that stands for recessive inheritance. This mnemonic is literally the ultimate cheat code for the wards. I'm going to leave you with this to chew on. Knowing how a single missing enzyme can just completely devastate multiple organ systems, how will recognizing that tiny, crumpled tissue paper clue reshape your very next differential diagnosis? Because early recognition here completely transforms patient outcomes. You're taking someone from a life of chronic pain and fractures to a life of near normalcy with ERT. It's a total game changer. So how will you apply this knowledge to save your next patient from severe, totally preventable complications? Think about that the next time you encounter a clinical mystery. Thanks for hanging out with me for this explainer, and keep learning.